Welcome to IMED Radiology's Where Does It Hurt? Musculoskeletal webinar series. So glad you could join us. My name is Sue Clute and I'm the IMED National Marketing Manager for Local Area Marketing and Education. IMED Radiology is proud to present tonight the third and final of our three-part musculoskeletal webinar series. Tonight's session will feature another of our highly respected radiologists, Dr. Justin Robert. Dr. Robert will focus the hour on the diagnosis and subsequent management of common shoulder complaints in general practice. At IMED Radiology, we have a vision to be the most respected and trusted medical imaging specialists in the world. Our vision is underpinned by our purpose, which is to save lives and reduce uncertainty. We are committed to consistently delivering high quality and expert care in each of our clinics and in every interaction. We are also committed to working with you, our referrers, as partners. Tonight's webinar is a prime example of this commitment. This is a commitment that can also be seen from within the patient journey. Did you know your patient can attend an appointment with you via telehealth or face-to-face, and the patient's request for imaging can be sent from your practice management software directly to us, safely and securely. The patient receives a text to their phone acknowledging receipt and containing a link to their imaging request. From here, patients in most regions can book their appointment themselves online immediately for a time and date that suits them. Together, these digital initiatives have totally streamlined the process from consultation to request, onto appointment, and importantly to diagnosis. The patient journey is enhanced and the results are back to you as fast as possible, reducing uncertainty. If you'd like more information on these digital initiatives and gaining access to electronic referral, or e-referral as we call it, please visit our website, imedradiology.com.au. Speaking of our website, I would like to mention it has a huge amount of resources regarding tonight's topic on MSK. And yes, we do record our webinars, and our website is where you will find any parts of our webinars that you may have missed. So, without further ado, I would like to introduce you to tonight's facilitator, Dr. Philip Herlstein. As a GP, Dr. Herlstein has had a long-standing interest in sports medicine and conditions affecting the musculoskeletal system. In 1988, he founded Midtown Medical Clinic in Melbourne, and in 1993 co-founded the Melbourne Sports Medicine Centre. Prior to the existence of the Sports and Exercise Physician Fellowship, Dr. Herlstein completed the one-year sports medicine course run jointly by the Australian Sports Medicine Federation and the RACGP. He served for several years on the Victorian Panel of Examiners for the Postgraduate Fellowship of the RACGP, and he's been involved with the North Melbourne and the Carlton football clubs. He's also worked as a doctor at the 2000 Olympics and been a member of the selection panel for Monash medical students and been involved as a tutor of undergraduate students at Monash University Department of General Practice. Today, Dr. Herlstein remains active with both his founding practices at Midtown Medical and the Melbourne Sports Medicine Centre, primarily in a management and mentoring role. Before I hand over to Dr. Herlstein, I do have a few housekeeping items that I'd like to mention. If you have any questions, please send those through the chat during the presentation, and we will answer as many as possible. If we don't get to all of them, we are compiling a Q&A of the most frequently asked, and we will be adding this to our website. At the conclusion of the webinar, please be sure to stay online to complete your evaluation form. Your feedback is important, as this allows us to continue to improve these education sessions. We are focused on keeping these sessions as relevant and as informative as possible. So suggestions for future content for webinars and feedback in general is really important to us. I will now hand over to Dr. Herlstein to introduce our guest speaker, Dr. Justin Robert. Thank you.
Thanks very much, Sue, and good evening, everybody. It's a pleasure to see so many of my GP and allied health colleagues have joined in this evening in the third musculoskeletal radiology seminar. This is about shoulder dysfunction and pain and radiology related to that. And you'd all agree that this is a common problem in general practice. And personally, I find that the shoulder joint is the hardest joint for me to examine and find I come up with an accurate diagnosis. I'm much more confident with other joints. And that makes the radiology of the shoulder much more important. And therefore, we really need to be able to know which investigations to choose and how to interpret them. So we're fortunate this evening to have the pleasure of Justin Roberts' expertise to assist us with that. Now, Justin obtained a bachelor's degree in human biology, medicine and surgery from Auckland University, and then completed his radiology training in Auckland. He subsequently completed an MRI fellowship in neuroradiology and musculoskeletal imaging based at Cabrini, East Melbourne, and Victoria House Medical Imaging. He has a keen interest in musculoskeletal imaging and currently works as part of the Victoria House Medical Imaging team, where he provides imaging and interventional procedures for many Australian sporting teams and the Australian Open Tennis. My practice, or our practice, is very fortunate to be amongst those practices in Melbourne that are able to offer Justin's expertise to our patients. For technical reasons, Justin won't be seen live, but there'll be just a vision of him, and he'll be able to continue with his presentation and guide us through this interesting topic. So thanks, Justin, over to you.
Thanks very much, Phil, and welcome everybody. Thanks for giving me the opportunity to talk. First of all, just apologies. For some reason, we haven't been able to get the live video stream going. So you'll have to listen to my voice. Please, if there's any questions during the course of the talk, please forward those on and we'll try and address as many of those as we can towards the end. We are starting just a little bit behind schedule, so I'll try and keep things motoring along and cover shoulder as best I can in as short a time as possible. Tonight I'm basically going to be giving an overview of the shoulder. We'll be talking about some of the common imaging modalities of the shoulder and how best to apply that in shoulder imaging. We'll talk about some of the common shoulder conditions and the appropriate radiological workup, and some of the common radiological procedures and things that we do for shoulder-related conditions. Finally, I'm just going to talk a little bit about vaccines and some of the issues that we're seeing related to that in terms of shoulder pain. And at the end, we'll try and address some of those questions that you may have. So to get the show on the road, I'll talk about X-rays initially. I think X-rays are an undervalued and underutilized resource. I think it's a very good starting point for anyone with shoulder pain. It's a cheap, readily available test that requires no appointments at the vast majority of radiological sites. Patients can simply walk in. Not every patient with shoulder pain is going to have the classic sort of bursitis and impingement or capsulitis or osteoarthritis. Sometimes there are unusual conditions, metastases, things like that. And it's important, I think, to always have X-rays as a safety net to exclude those other pathologies. So it's good for looking at the bones, it's good for looking at joints, it's good for looking at soft tissue calcification, and it's also always good to assess for subacromial spurs and things like that which may be contributing to mechanical impingement. Shoulder X-rays are also useful for assessing cuff integrity. It gives you an indirect assessment of cuff integrity. We're not looking at the cuff directly, but you can get some important clues as to whether or not there is a cuff tear by some plain film findings. So we always do several views of the shoulder. We'll do an AP, we'll do AP internal and external rotation films, as well as a subacromial outlet view, and we'll also be looking at, we'll also get an axial view to get another look at the shoulder joint. It's important to do a number of views because some pathologies you're only going to see on some of the views, and they can be obscured in a limited series. So this is just a standard AP film of the shoulder. This is the same view with slightly external patient rotation, and if we magnify things up a little bit further, we can see that there's a small amount of gas within the joint, and that is a fairly good indicator of the cuff actually being intact with a tight seal, which is allowing for that accumulation of tiny little bit of nitrogen gas. Now, that's obviously not a universal finding, but when you do see it, it is a helpful sign that there is no full thickness cuff tear. That's the axial view that I spoke about. It's a good global overview again of the shoulder, and just assessing if the patient has osteoarthritis. Is it more at the front of the shoulder, which is at the bottom of the image where we can see the coracoid process, as opposed to the upper part of the image where you have the posterior glenohumeral joint space. This patient has a large subacromial spur. Now, I've forgotten to put an arrow on that, but you can see that directly above the humeral head. And other examples of patients in whom there is a subacromial spur on the left on an AP projection, and on the right we've got that outlet view where you can see that large subacromial spur anteriorly, which is going to be predisposing to supraspinatus and bursal impingement. This is another example of X-rays assessing cuff integrity. We can see superior humeral head migration. There's no joint space beneath that acromion, and that is a clear indication that there is a full thickness cuff tear, in addition to some glenohumeral osteoarthritis. Now, obviously, ultrasound and MRI and those sorts of things can exactly assess the parameters of the tear and exactly which tendons are involved, but plain films alone are going to show you that there is a full thickness cuff tear there. This is another patient. This is a standard AP view, and this is just to highlight pathologies which you may not necessarily see on a standard view. If we get the patient into rotation, brings this pathology into view, where we can see some hyperdense material above the humeral head. And that brings us to the first poll question. What is this condition? So people can start filling that in now. Is it an old avulsion fracture? Is it calcitic tendinopathy? Is it a paraosteal osteosarcoma? Or is it an artifact? Just back to that picture. And back to our options. I'll just give you a little bit of time there. So all right, I think we've got a clear winner. Most of you put in there calcitic tendinopathy, which is the correct answer. A few people have put in an old avulsion fracture. And there's also a couple of people that have put in a paraosteal osteosarcoma. The correct answer is calcific tendinopathy. It's a fairly common cause of shoulder pain, obviously not in the big numbers of bursitis and capsulitis, but it is a common cause for significant pain. Now, just going back to the pictures over there, on the AP projection, it's fairly hard to see that calcitic tendinopathy because it is overlying the humeral head, but this is the hyperdense material which is actually hiding behind that humeral head and that greater tuberosity, which is not yet brought into profile on that other image. Now, a lot of patients get referred into our practice for adhesive capsulitis. Often in the older age group, they may in fact have osteoarthritis. This is just a little reminder slide in there for me to highlight to you the importance of always getting plain films to see whether or not there's osteoarthritis, which may be mimicking capsulitis, or it can be a combination of the two. Ultrasound's extremely useful for superficial tissues around the shoulder. It's good at looking at the tendons, the acromioclavicular joints, and the bursa. The great advantage ultrasound's got over plain films and MRI and other imaging modalities is really the fact that it's a dynamic assessment. We can put the patient in various positions and we can get them to reproduce their symptoms. Obviously, when we're looking for bursitis, we will get the patient to slowly abduct their arm, and we can assess whether or not there is visual impingement occurring in relation to that bursa as it starts to pass beneath the acromion. We can assess the patient clinically at the same time. At our practice, we will routinely go in, the radiologist that is, in addition to the sonographer, have a talk to the patient and try and find out what their chief clinical complaint may be. I find at my particular practice, I can often make the diagnosis from the clinical picture alone. And that's not to say that our referrers haven't got the correct diagnosis, because often that is on the form, but it's a good opportunity for us to confirm that the ultrasound findings that we're picking up on marries up with the clinical presentation. The other big advantage ultrasound's got is its ability to compare with the other side at the same time, which is not something that you have as a matter of routine when you're doing MRI imaging, for example. Patient can also often point to where the pain is. So if they're highlighting the ACJ, we'll obviously scan that area a bit more closely, and other various points around the shoulder. So we can target the image, the imaging that we are doing to the area of interest a little bit more carefully. And finally, ultrasound is our chief sort of interventional modality. So a lot of our injections will be done under ultrasound. So our bursal injections, our calcific tendinopathy injections, if we're targeting ganglions. We can also do intra-articular joint injections under ultrasound, but for the mainstay, that will be done with the X-ray guidance. This is an ultrasound image. And again, bottom arrow on the right just is highlighting the tendon. The top arrow, a bit more to the left of the screen, is the bursa. The bursa is that slightly hypoechoic layer between the tendon and the more echogenic layer above, which is the subdeltoid fat plane. And that's the area that we will see, which is slightly thickened. So now if you had me on a video, I would have been showing you with a model exactly how we would obtain that image, but unfortunately you're going to have to miss out on that. So moving on, this is just another example of ultrasound where we can compare the two sides. On the left, we've got calipers on a bursa, which is not quite as thick as the image on the right, where the bursa is thicker. And in this particular patient, the left side was the more symptomatic of the two, which would coincide with the ultrasound images that we're having there. This is an abduction image where we actually get the patient to bring the arm away slowly from their side, and we would assess the bursa. We would find out from the patient as they are doing that, is that hurt as you're doing that? And at a certain point, as they're slowly bringing the arm away from the side, we would find out, you know, is it at 30 degrees, is it at 60 degrees, is it at 90 degrees that they're getting the pain? And we can assess that bursa as it's coming up. This bursa is slightly thickened as it's coming up away from the bursa, as the arm is coming away from the side. On the top arrow to the right of the screen is the slightly more thickened bursa. On the left, the bursa is not quite as thick, as that is the point at which it's getting impinged between the beneath the coracoacromial ligaments. This is an image of a full thickness cuff tear. We've got retracted tendon on the left of the screen, some arrows there for you just to get your bearings. On the left is the retracted tendon end. The arrow on the right is where the tendon should be inserting as per the image I showed you earlier. And beneath that is the articular cartilage overlying the humeral head, which is the bright line at the bottom of the screen. That's curvilinear bright line. Just a quick recap of our tendon tears and tendon pathology. You'll often hear us talking about bursal surface tears, articular surface tears, and intrasubstance tears, etc. So we've got the acromion, which is the uppermost little osseous component that we've got on the diagrams. At the bottom, we've got a humeral head. Between that is the tendon, which looks a bit like a muscle in these diagrams. The bursa is sitting on top of the tendon, and then you've got the joint space beneath. The image on the top left is of subacromial spur formation impinging on that bursa and tendon. The next image on the top right is a partial thickness bursal surface tear. Bottom left is a partial thickness articular surface tear. And on the bottom right is a full thickness tear where the bursal space and the joint space communicate between the two. And in that circumstance, if we were to do a bursal injection, it would communicate with the joint, and vice versa. If we were to do a joint injection, it would communicate with the bursa. Now, just a quick recap. Obviously, not all indications are Medicare rebatable, but there are specific conditions in which patients will get benefits payable. And I probably don't need to run through all of those, but it's most of the common referrals that we see would meet Medicare guidelines. But occasionally we will get a referral that just says shoulder pain or something fairly nondescript, which means we need to just find out exactly what the referrer is interested in knowing. Now, MRI is the single best overview of the shoulder. It's particularly good for when X-rays and ultrasound are unhelpful. To use a military type analogy, I sort of put MRI in the stealth bomber kind of mode. It's one of the global overviews of the shoulder where you can see everything both inside the joints, the bones, the tendons, the ligaments, everything really, really well. As opposed to ultrasound, where it's a bit more of a targeted imaging approach, for example. So MR is particularly useful for looking inside the joint, looking at the cartilage, looking at the labrum. It's good in circumstances in where we're wanting to characterize other findings that we may have seen in other imaging modalities. So, for example, on an ultrasound, you may have seen a partial thickness bursal surface tear. It might be high grade. We're not quite sure whether it's a full thickness tear or not. MR is going to provide that clarity. It's also going to provide the opportunity to try and work out, is that tear repairable or not? And then it's also good for looking at other causes of shoulder pain that are not in the standard causes of pain. For example, patients in whom there's Parsonage-Turner syndrome, other things that are less commonly seen. Now, I've just mentioned sensitivity at the bottom of that slide. With MRI, sensitivity is both a blessing and a curse. If I was to report a scan on someone in their 70s, I could probably find, 5 to 10 abnormalities on it, but only one of those findings may be the clinically relevant issue. So it's always important to try and marry up the MRI findings that a radiologist may be giving you in their reports with the actual clinical picture. So it's hypersensitive. We're going to see lots of abnormalities, but it's always important to take that back to the clinical picture. If you tuned into the lumbar spine and knee talks given by Dr. Andrew Rothstein and Tom O'Shea, you'll be aware there's multiple contraindications. Basically, ferromagnetic implants or electronic implants are big no-nos as far as MRI is concerned. You're probably all familiar with the picture on the bottom right of the screen. MRI is an extremely powerful magnet, so any ferromagnetic particles in the patients can be highly hazardous. So we do take that whole component of safety very, very seriously in the whole MRI process. Now, metal that is embedded in or around the shoulder, so if the patient's had previous surgery in terms of anchors, that is a safe, provided it's not in the immediate post-surgical window. Now, a couple of MRI examples over here. We've just got a normal image on the top left, or sorry, on the left. On the right, we've got a tear of the superior labrum with a paralabral cyst. I haven't got time to show all sorts of examples, but just thought I'd show that as a neat example for shoulder MRIs. CT is another imaging modality that we can use in shoulder workup, but I don't believe it's a mainstay, particularly for general practice. Occasionally it can be useful in patients in whom there's a complex fracture and we're trying to work out, is it something that needs surgery? Often CT will be performed on a surgical referral basis, trying to work out how much bone has been lost in those patients in whom there's been shoulder dislocation. This is another major use that we will be using CT for, where a surgeon's wanting to know how complex is that fracture, for them to try and marry all those pieces of bone back together again. MR arthrography and CT arthrography are two other things that we will sometimes do. In our particular institution, we don't do this very often. Other places around the country will be doing arthrograms as a matter of routine in patients in whom they are worried about labral tears. I personally don't believe it's necessary for the vast majority of patients. Usually if there's a significant labral tear there, we'll be able to make that diagnosis quite comfortably on routine MRI. But it's basically the process where we put dilute gadolinium into the joint under X-ray guidance and then get MRI following that, and that contrast will then highlight the tear slightly better in some patients. CT arthrogram, something that we would only ever do for those patients in whom their MRI is contraindicated because they've got implant or some other reason why they can't have an MRI. And it will also help assess the joint to a better degree. This is an example of an MR arthrogram where there's quite a lot of fluid in the joint, which has been introduced by your friendly radiologist. On the left of the screen is an arrow demonstrating a labral tear that's displaced overlying the anterior glenoid. On the right is the same view, but that is a non-chat suppressed image, which is better for anatomy, as Tom O'Shea was talking about on his knee talk 2 weeks ago. And on the left, you've got fat suppressed imaging. As a general rule, fat suppressed imaging is very good for highlighting pathology, whereas non-fat suppressed imaging, where you've still got fat, is very good for anatomy. This is a CT arthrogram image, which is your correlate of the MR that I showed before. So just back to the MR, this is the CT. So we've got dilute contrast in the joint. That is highlighting the labrum and the cartilage by those two arrows that we've got on the image there. So this would be something that you would do in a patient who, surgeon, for example, didn't want to go straight to surgery. They may want to assess, is there a labral tear? It's not something that we do very commonly, but there is that extra safety net there, or that opportunity to assess the joints a little bit further. CT with metal reduction is one thing that is also quite useful for patients in whom there is a total shoulder replacement or a whole lot of metal wear that requires further investigation. Standard CT sometimes isn't too good in assessing total shoulder replacements. Usually this is going to be referred from a surgeon rather than GP referral, but it's something just to be aware of. So I won't talk about that too much. We've got a 4D CT at our practice in Melbourne as well. There are a number of practices elsewhere in Melbourne that have also got it. Again, this is something that would be pretty unusual to ask for, but it's for those rare conditions where you want to get dynamic CT images, where we're looking, for example, for sites of bony impingement, such as in snapping scapula, where there may be an exostosis which is impinging on the bone. Now, there is a video associated with that, and I just don't know whether or not we can get that going. Okay, I've got a message that is playing, which is good. And sorry, just want to get back to my talk over here. Sorry, slight technical hitch there, but back up and running. So nuclear medicine is probably the last of the imaging modalities that we would use in the assessment of shoulder pain. Sometimes it is required. We used to call it unclear medicine when I was doing my training because images were fairly fuzzy. Things have moved on from that, where we can now fuse nuclear medicine bone scans with CT images, such as on the right of the screen, where we've got a acromial stress fracture in a patient who happens to have a reverse total shoulder replacement. So the orange sort of glow that we can see there is a nuclear medicine study that is fused with the bone scan. So there's osteoblastic activity there associated with that fracture. Now, obviously, there may not always be a fracture, but you would get the uptake before you see the fracture. So that would be an example in a patient who couldn't have an MRI, where a bone scan would be able to give you the diagnosis before any other imaging modality could. Now, very briefly, just talking about imaging-guided injections. As I said before, most of our injections would be performed under ultrasound. So subacromial bursal injections, AC injections, and ganglion injections would be performed under ultrasound. Glenohumeral joints we can do under ultrasound, but X-rays X-rays would be the mainstay for that, where we can prove that we were in the joints with some contrast. Hydrodilatation would be one of the most common procedures that we do at our particular practice for frozen shoulder, and it's very nice on that because we're putting in a large volume of fluid in there just to see whether or not there's any leak during the course of the procedure, as you wouldn't be able to get that information from an ultrasound guided procedure. This is a X-ray room or hydrodilation room. We've got Frank Burke in the picture there, who pioneered hydrodilatations in Australia. We've got our patient who's got an arm and external rotation, just allowing for easy access of the needle, which we use, which we put in from an anterior approach. I often get questions from referrers, do we put steroid in with our hydrodilatations? A lot of people are under the impression it's simply extension of the joints. It's both cortisone as well as local anesthetic and saline. So there's both the cortisone, which is an anti-inflammatory component, as well as saline, which gives you the stretch, which allows the shoulder joints to be stretched up back to its normal capacity and ease up shoulder movements. And I'll talk about that a bit more shortly. This is one image from a shoulder hydrodilatation. We've got a needle in the joints. We've got a bit of contrast and air in the joint, which is just proving that we're in the right spot. and the contrast would allow us to determine whether or not there has been premature leak before we get our full volume that we would like to get into the patients for maximal benefit. So an example of a subacromial Bursa injection, we've got the needle in the Bursa, which is more distended on the right image. So just going to talk about some clinical conditions. I'll do this in a slightly clinical sort of format, just to give you the opportunity to think about how you would be dealing with these patients should they come into your clinic. So first case is a 17-year-old student who had a football injury on the weekend. He falls onto his left arm, he's a loud clunk or a pop, and has acute shoulder pain, shoulders feeling unstable. It's remained painful ever since. And he can move it in all directions, but there is some discomfort, and he comes to see you several days later. So that brings us to our next poll question. What do you think the most likely diagnosis is? Is it impingement? Is it a cuff tear? Is it a dislocation? Or is it a malingera? So I'll just give you folk a little bit of time to fill that in. Okay, we've got numbers coming in, that's good. Okay, so we'll close that poll there now. So the correct answer is revealed in the next picture. For those of you who thought he was a malingera, this is what the shoulder looked like temporarily. Clearly a dislocation. So as I was talking about in the beginning of the talk, X-rays are always an important component. I'd still be performing X-rays on a patient in whom you suspect there was a dislocation. We can see is there a big osseous Bankart fracture, is there a Hill-Sachs lesion, and obviously is it end-located or not. This particular patient's had a dislocation. On the left of the screen is normal glenohumeral congruence. The image on the right shows a Hill-Sachs lesion. The MRI equivalent, we can see a Hill-Sachs lesion and a labral tear. So, sorry, image on the left is the Hill-Sachs lesion highlighted by the arrow, and the arrow on the right image is a tear of the labrum. So it's a fibrocartilaginous Bankart lesion. So I often will see in my practice, or not often, but occasionally we referrals for an ultrasound. Really, there's no place for an ultrasound in the context of someone in whom you suspect there's been a dislocation. It's really plain films and MRI. I think ultrasound in that context would really be a little bit of a waste of time. So next case, we've got a 56-year-old who has been fairly active, doing triathlons, doing yoga, and working out at the gym. Injured their shoulder last year and has, for months, had pain and thought she had a pulled muscle. Tried rests, has had to reduce her activities, had trouble with the activities of daily living. So I'll let you have a think about what that may be. This isn't a poll question, but this particular patient had a full thickness cuff tear. So we've got two images over here. We've got both the ultrasound on the left of screen and on the right of screen, the MRI equivalent. The full thickness tear, retracted tendon, and we've got a high volume bursal effusion, free communication of the joints and the overlying bursa. Again, just arrows highlighting cartilage and that tendon tear on ultrasound. In patients in whom there is a full thickness tear, we will often do MRs for those that are interested in getting an orthopedic opinion, because ultimately the surgeons want to know, is there any point repairing the tendon? If the muscle is grossly atrophic, there's not much point in performing any operation. And in this particular example, this is a supraspinatus muscle belly, which is fairly atrophied. There's a whole lot of fat in that suprascapular notch, and bottom line is if there was more fat than muscle, it's not going to be a repairable tendon. So next case, a 61-year-old who's active in sports, has had 4 months of shoulder pain and feeling of reduced range of movement. They've had night pain. They've had pain radiating to the deltoid tuberosity, difficulty putting on the bra and reaching for the seatbelt and hanging out the washing. So that brings us to our next poll question, and I'll just, so is it osteoarthritis, tendinosis, bursitis, frozen shoulder, or could it be A or D? I'll just put up the history again whilst you fill out the poll. So it's a 61-year-old, feeling of reduced range of movement, pain, particularly at night, and it's radiating to the deltoid tuberosity. Okay, the numbers are rolling in, and most people have got the correct answer. Let's give you a few more seconds. Okay, so we've got an answer for everyone's. Most people have put in E, some people have put in D, some C, and some B, and even some A. The correct answer for this is osteoarthritis or frozen shoulder. D is probably the more correct, but the correct answer for me anyway is A or D. We see so many cases of frozen shoulder, at least clinically. You then get an X-ray and they actually have some osteoarthritis as well. So I think any time a patient has pain radiating to the deltoid tuberosity and there's reduced movements, frozen shoulder needs to be on the top of your list. But the older they get, there's often going to be an element of osteoarthritis there as well, and it's important to get your X-rays as well as your ultrasound in this particular context. So just a quick recap of adhesive capsulitis. There's lots of movements. They have both active as well as passive loss of range of motion. We see it more commonly in women than men. We also do see it in patients who are diabetic. There's obviously a process where it's painful initially, it then becomes more frozen and the pain subsides, and then gradually over time there's a thawing process and the movements gradually improve. But it's often a slow and debilitating process, and the patient will only get back to normal after 24 months. I think the most common referral or modality that we'll see for this is ultrasound, and I do believe that's the correct one. Although there are a number of places elsewhere in the community, in other practices, if I sometimes go there, sometimes the sonographers are not as familiar with the diagnosis of frozen shoulder. And in that particular setting, sometimes MRI is more beneficial. I do think for the mainstay, clinical diagnosis is the most important for this. I will often make the diagnosis for my patients when they come into the ultrasound based on the clinical picture. On ultrasound, we can see some things. We can see fluid in the long of the biceps sheath. We can see inflammation in the rotator interval. Sometimes we can see thickening in the axillary pouch, but the most important is really that slow or that loss of motion that's developed over a course of months. And typically we're seeing patients who've had symptoms for 3 to 4 months by the time they turn up. Treatments is physiotherapy. Shoulder hydrodilation is something that we do a huge amount of at the institution I work at Victoria House. I do think it's a very useful maneuver to try and get the patient sped up on that pathway so they don't have to take 24 months to get back to normal. But it often needs to be done in conjunction with physiotherapy, and we would usually advocate the patient get some physio day 3 to day 5 following the procedure. Final option, should the patient not respond to hydrodilation, would be manipulation under anesthesia or an arthroscopic capsulectomy. MRI example of adhesive capsulitis. Now, I've forgotten to put arrows on this, but at the bottom of the images on both the left and the right, there is a cloudy area of increased signal where the joint capsule between the humeral head and the inferior glenoid meet. That is basically a thickened edematous capsule, and that would be someone who was in the earlier stages of adhesive capsulitis, where it is quite painful and they do have reduced range of motion. So I'll move on to the next case, 44-year-old who's had ongoing niggly pain for 18 months. And then all of a sudden, whilst vacuuming, has had sudden, very severe shoulder pain, sore to touch, extraordinarily sore to move, very reluctant to move things. And it's like the worst pain I've ever had, doc. Now, this is a fairly classic presentation, and it's something that I showed an example of right at the beginning of the talk, and that is calcific tendinopathy. Often that calcium will be sitting dormant in the patient's tendon for months to years, and they will be doing something fairly innocuous. The tendon, or that calcium, will leak out of the tendon into the surrounding soft tissues, and that sets up that acute severe inflammatory process, which is extraordinarily painful for the patient. Often when they come into my practice, I'll be calling GP up there and then, even if they haven't asked for an injection, just because the patient's in such severe pain that you sort of feel duty bound to try and do something for them there and then. And I'll get to what we do, but this is just the ultrasound pictures. On the arrow, or on the image on the left, we've got an arrow of some echogenic calcific tendinosis. And on the image on the right, the echogenic material's got increased vascularity around it, which is those orange blobs of neovascularity. And that is a hallmark of pretty severe inflammation. And what we do for these patients is actually put a needle into that area of calcification. We'll do a process, what's called barbotage, where we will put in local anesthetic to flush, at least flush the calcium and try and aspirate as much of that calcium out as we can. So we will put some preliminary local anesthetic in, and then further local anesthetic into the calcium, and gradually draw up as much as we possibly can. We've got two images here on the left and the right on the X-ray. It's a before and after of calcification. So we can make quite a significant improvement to the volume of calcium that's free in the bursa as well as in the tendon. And we often draw up this thick, sort of milky, sort of calcific substance, which you can see in that rather blurry image at the bottom. And in addition to aspirating it, we'll also then put cortisone into the calcification and the overlying bursa as well. And that often will make a huge difference to the patient. There'll be a huge sigh of relief as the local kicks in. Usually it's very sore initially, but 30 seconds to a minute into the procedure, they're usually already thanking you. And it does make a huge difference. sometimes the calcium's been there for quite some time, and we can't actually aspirate too much of that. But just putting some steroid in there alone can gradually cause the body to resolve things and make the whole process a whole lot better. Worst case scenario is the patient may need some surgical debridement. Now, just a final comment, just as a closing slide here, just got to talk briefly about vaccines. Everyone at the moment is running out and getting their COVID jabs. I am seeing quite a lot of patients presenting with shoulder pain following vaccinations, and I do think it's important to take those patients that are presenting with pain following vaccines seriously. Sometimes the needle's placed into the bursa, they can actually get an iatrogenic bursitis. I've had several patients now in whom the needle simply wasn't in the deltoid at all. It was actually in the supraspinatus tendon, and patients have had iatrogenic tendinopathy, or basically traumatic tendinopathy, as a result of incorrect needle tip location. And the other thing is, particularly with the mRNA vaccines, is patients are getting a lot of auxiliary pain and things related to quite pronounced lymphadenopathy. And I haven't had any patients yet with upper limb DVTs or anything like that related to the vaccine, but that's something to bear in mind. So I think that might be the end of the talk. So we'll just see if we have any questions, and we'll address those now.
Thanks very much, Justin. That was really informative and helpful for us all. And you certainly created some interest with the questions. I'll try and ask as many questions as we have time for. I know we started a bit late, so I think we'd be given for going a little bit longer. One of the questions asked is, why is it that a patient who is just post-op, in the post-op period, unable to have an MRI, and then the same patient able to have one several months later?
Well, it's all about whether or not that metal is mobile. So in the initial phase, when metal goes into the bone, it hasn't solidly fixed. But over time, there's often a bit of bony ingrowth and just more solid bony union around the metal wear, which just fixes things in place. That's the theory. I mean, often there's titanium metal that's going in there, which isn't particularly susceptible to the magnet anyway, so it's probably a moot point. But it's as a general rule, we prefer to just make sure that any metal that's gone in there is completely solidly bound and there's no room for movement.
Excellent, thank you. Now, there are a whole lot of questions about hydrodilation and adhesive.
Yeah. I thought there might be.
Not surprisingly. One of them is, when do you think is the most appropriate timing for hydrodilation in someone who you've diagnosed with adhesive capsulitis?
It's a good question, actually, because I've debated with myself when is the right time, and I don't know that there is actually a good answer. I think the time to do it is the time that you've got the diagnosis and the patient presents. There are some people who believe if you do it early on in the piece, because there's that 2-year sort of period where patients are going to be experiencing the condition, it may come back. But I personally think it's best just to get on with it. I don't think there's any point in delaying it because they've presented for a reason. It's best just to get on and do it. I think if for some patients, the hydrodilation may not be a lasting phenomenon, and I would repeat it at that stage. But I would certainly wouldn't be repeating hydrodilatations very close back to back. You'd be wanting to have a decent gap between any hydrodilatations. So at least a few months between as a general rule of thumb.
It's a very relevant question being asked. Can hydrodilation or cortisone injection be done in shoulder for patients who are anticoagulated, or does it need to be stopped?
My rule is it doesn't need to be stopped. It's a very atraumatic procedure. You're putting in a blood test needle, so it's a 22 gauge needle. There's very little in the way of trauma that's being done. Yes, we do stretch the lining of the capsule up, but the aim of the game is to stretch it up without rupturing it. So we gently distend things. We always stop when the patient is too uncomfortable. So as I said in the talk earlier on, we aim for a 35 ml volume, but if it gets too uncomfortable before we get to that mark, we stop. Or if I feel like that's all that that particular joint can accommodate, we will stop as well. So anticoagulation is not a contraindication.
Excellent. Michael asks, when adhesive capsulitis is identified on MRI, how long is it likely to have been there? 3 months, 6 months, or how long do you think?
Usually on MRI, when we're seeing adhesive capsulitis, it's in the earlier stages. So it's usually sort of in the first 6 months is my guesstimation. It's a bit hard to know. It's one of those things that some patients will have clinical adhesive capsulitis and their MRIs may be completely normal. So I would not be using MRI as a exclusion for the diagnosis, but it's more for a confirmation of the diagnosis. So I hope that makes sense. So ultimately, it's really the clinical diagnosis that is the most important thing for adhesive capsulitis. MRI can confirm it, but you can't absolutely exclude it being there if the MRI doesn't pick up on it. And again, there are some practices where adhesive capsulitis may not be on the reporting doctor's radar, and they may not even think about it. So it's one of those things where, you know, people can often focus on the tendons and the labrum, and it needs to be on the referral. So the most important thing is make sure the referral is good, and then people will know where to look.
Excellent. I think that's a good message. Now, Mac asks that bursitis is very common but can often be asymptomatic. Whilst injections can be beneficial if it's the source of the pain, he finds it often injected simply because a patient has some shoulder pain and the ultrasound shows bursitis. Without much benefit, any advice or thoughts on what else to look for that might be a good indication to inject the Bursa other than appearing on ultrasound?
Well, I think bursal thickening alone should not, a lot of places, there can be a tendency for people to label bursitis if the bursa is thickened. That shouldn't be the only measure as to whether or not there is bursitis there. There should be pain associated with abduction. So you have to have the clinical features of bursitis, so pain with abduction. There should be clear impingement. And if the patient has pain and there's bursal thickening, well, then I think it's perfectly reasonable to inject that bursa. And should there be no response to that bursal injection, well, then that might be the time to think about alternative causes. Is there something else causing pain? Is it something intra-articular? And that might be the time to think about an MRI to try and work out what else might be causing symptoms.
Excellent. Now, a relevant question for those people who aren't practicing in the city, can hydrodilation be done by any radiologist in rural places?
Can't answer that because I don't know what their skill sets are. I think at the end of the day, at least with our organisation, with IMED, all of our doctors are approachable. I would ring them up, find out whether or not it's a procedure that they do. It's a very commonly performed procedure, and just about every radiologist would be able to do it and would know how to do it. So I don't see it being an issue, even in a rural practice.
Galena asks, what's the best interval time between steroid injections if they need a repeat?
Well, on average, most steroid injections would last 3 months. Sometimes, depending on needle placements and just the patient and their condition, it may not last that long. I would usually wait a month before I would do it again. So, for example, let's say you did a bursal injection, you were adamant that the bursa was the problem, that patient had no response to that initial injection. I would give it a month before you're truly working out whether it worked or not, and then do it again. So, yeah, I'd say about a month.
Eric asks, is it safe to eject steroid for a full thickness tear of the shoulder? I presume he means the cuff.
Depends on whether or not you're interested in the patient having surgery or not. If the patient was a surgical candidate, I would hold off on doing steroid. Some surgeons are very reluctant to perform surgery following steroid injection because steroid makes the tissues more friable. So if surgery is on the radar, get an orthopedic opinion first. If the patient is clearly never going to have surgery, well then, obviously a steroid injection would be fine.
Okay. Somebody else asks about hydrodilation and the fact you've suggested starting physio within 3 to 5 days. They've just made the point, which is a practical one, that would have been physiotherapy ahead of time rather than having to face then a delay.
Sorry, breaking up. Can you repeat that again, Phil?
Yeah, somebody has just helpfully suggested that if someone's going to have a hydrodilation, it's suggested that you book the physio appointment before you have procedure so you can still get in time to start your treatment soon enough. That's obviously...
Yeah, well, I would agree with that. I mean, I think depending on where you're situated and how many physios and things you've got, that would make sense. But often, you know, the hydrodilation can be quite beneficial on its own. So, but yeah, to maximise return from the hydrodilation, I do recommend getting that physio appointment. And if necessary, yep, you may need to book that in conjunction with the hydrodilation.
Okay, well, I think we're really finished our time now, and we don't want to keep people from their dinner too long. So I'd like to, on everybody's behalf, thank you so much, Justin, for an excellent presentation and for dealing with our questions. And apologies to those questions we didn't get to answer, but we'll attempt for them to be answered via email communication. Also, for those that are wondering why Justin's not been visible in person, it's not because he's doing it in his pajamas. He's actually just had a fault with his video, so he's actually beautifully dressed, I'm sure. So I'd like to thank...
I am actually.
I'd like to thank you very much and thank everybody for their participation and hand back to Sue.
Thank you, Dr. Robert, for the very informative presentation tonight, and thank you, Dr. Herlstein, for facilitating. I'd like to also thank our audience, for joining us tonight. I look forward to your feedback, so can I ask you to please stay on the line where you'll be redirected shortly to complete your evaluation of tonight's presentation. Once again, thank you for your attendance. Stay safe, stay well, and good night.